Good day, everyone. Our talk today is about susceptibility-weighted imaging in terms of its clinical application. Although simple T2 star weighted gradient images have traditionally been used for the detection of iron and blood products and calcifications, modern SWI sequences have several features and enhancement making them superior. For example, if you look to this gradient weighted images, it looks normal with no significant abnormality. But if we look to the SWI image, you can detect multiple areas of blooming artifacts. Going back to the gradient weighted image, maybe you can see retrospective this focus only, while the other foci are not visualized. So susceptibility weighted image is a recently developed magnetic resonant imaging technique that is increasingly being used to narrow the differential diagnosis of many neurological disorders. It exploits the magnetic susceptibility differences of various compounds, including deoxygenated blood product, iron, and calcium, thus enabling a new source of contrast in MRI. Susceptibility weighted image is particularly useful in multiple settings. Trauma, for example, acute neurological presentation suggestive of stroke, occult low-flow vascular malformation, cerebral microbleeds, intracranial calcifications, neurodegenerative disease, and brain tumors. So when you run the SWI in 3 Tesla MRI machine, you will get this original magnitude image. And through the post-processing, we can get 3 different sets of images. The first one is the phase image. And you can notice here the iron in the basal ganglia, and these are the subcortical U fibers. So this is called original phase image. The second one is processed single magnitude image. Again, you can see the iron in the basal ganglia and the subcortical U fibers. The last one is minimum intensity projection, and this is my favorite to look at in SWI. And again, you can see the iron in the basal ganglia, the subcortical U fibers, and the cortical veins. The minimum intensity projection images represent a projection through a series of usually 4 sections that takes the minimum value of the signal intensity at each pixel to create an effective section of 8 mm that better shows the continuity of the veins. So how to differentiate blood from calcifications in SWI? Let's have an example. If you look to this MRI, this is a T2 and this is T1. Obviously, you can't detect any abnormality in both images. But if you look to the SWI, you can see an area of blooming artifact in the lateral ventricles, which indicates intraventricular bleed. To be sure that this is a blood, you have to look to the phase image. So if it's bright in the phase image, this is blood. So bright for blood and B for B. What if it's a calcification? Let's have an example. So this is a calcified granuloma in the CT. In the SWI, it's of low signal, and if you look to the phase image, it's also low. And so this is a calcification and not blood. And this is the way how to differentiate between blood and calcification in SWI image. You will need to look at SWI and then the phase image. Starting with the application of the SWI, the first thing is cerebral amyloid angiopathy. We all know that in cerebral amyloid angiopathy, we have deposition of beta protein in the basement membrane of the small and medium-sized vessels, leading to fibrinoid necrosis of the wall and then leakage of some blood around the vessels. So if you look to this patient, this is flare and this is T1, you can see an area of bright signal intensity denoting hemorrhage in the left occipital loop. And this is a periventricular bright signal intensity, what we usually call small vessel disease related changes. But if you look to the SWI, you can see multiple areas of blooming artifact in both cerebral hemispheres, more obvious at the cortical and subcortical regions. Again, this is the area of hematoma or lobar hemorrhage, and these are foci of blooming artifact in the cortical and subcortical location, and this is diagnostic of amyloid angiopathy. So with single SWI image, you can confidently diagnose the amyloid and angiopathy. Another examples, multiple areas of blooming artifact or microbleeds in the cortex and subcortical areas, which is diagnostic for cerebral amyloid angiopathy. The second thing is hypertensive cerebral angiopathy. It's a similar pathology like the cerebral amyloid angiopathy, but the only difference is in the distribution. So if we look to this T2 weighted images, we can see bright foci at the region of the basal ganglia. Usually we call it lacunar infarcts or small vessel related changes. But if you look to the SWI, you will find multiple areas of blooming artifact at the region of the basal ganglia. And here's the difference between the hypertensive angiopathy and cerebral amyloid angiopathy, which is the distribution of areas of microbleeds. So if it's just cortical and subcortical in location, so this is cerebral amyloid angiopathy. And if the distribution is in the basal ganglia, brainstem and cerebellum, so this is diagnostic of hypertensive angiopathy. What about traumatic brain injury? Diffuse axonal injury is a type of traumatic brain injury due to shear forces generated by rapid acceleration or deceleration of the head, causing shearing of the axons. The extent of the axonal injury has been shown to correlate with a poor prognosis, as do parenchymal hemorrhage. Recent studies have shown that SWI is more sensitive than CT or gradient sequences in terms of detection of the suspected hemorrhage or hemorrhagic foci in traumatic brain injury. So this is a young patient subjected to a motor vehicle accident, and you can find small areas of hemorrhage at the left frontal lobe. But if we look to the SWI, you can detect the true extent of the disease. Here are multiple areas of blooming artifact, much more obvious than in T2 weighted images. And this explains why this patient left with many disabilities even after 2 years of the accident. Again, this is another example. This is a parenchymal hemorrhage, this is subdural hemorrhage, and this is subarachnoid hemorrhage in the CT. If you look to the T1, again, this is the hemorrhage, the parenchymal one, and this is the subdural one, but you can't appreciate the subarachnoid one. In diffusion weighted image, again, the parenchymal hemorrhage, maybe you can appreciate the subdural one and subarachnoid one. But if you look to the SWI, there are multiple areas of blooming artifact, and look to this region at the temporal lobe right side. It's not seen in all sequences. And if you look to the phase image, it's bright, so this is blood and not calcifications. So another clinical application, CNS vascular malformation. True arteriovascular malformation usually are present at birth and can become large with time. They are characterized by their high flow and therefore can be detected by conventional MRI or MR angiography. In contrast, low flow vascular malformation, including cerebral cavernous malformation or developmental venous anomalies and capillary phalangoectasia, may be inapparent on fast spin echo sequences because they mainly contain slow flow small vessels. These lesions may be responsible for epilepsy, recurrent subarachnoid hemorrhage, and hemosiderosis. Because the incidence of hemorrhage from occult cerebrovascular malformation is related whether they have ever bled using SWI to detect previous bleeding helps prognostic on the future risk, or help to predict the instance of future risk. The MRI findings of capillary telangiectasia are variables depending on the presence of calcification or cavernous malformations. This depends on the calcification, hemorrhage within the lesion, but they typically show a mixed signal intensity, usually called a popcorn-like. Since the recurrent microhemorrhages occur in these lesions, they may contain deoxyhemoglobin acutely or hemosiderin chronically, and both are dark on SWI. So, if we look to this patient, who is a patient with a history of familial cavernous malformation, underwent magnetic MRI just for screening, you can see just an area of susceptibility at the right frontal lobe, which indicates cavernoma. But if you look to the SWI, you can appreciate how many cavernomas this patient have. So this is the true extent of the disease, and by single image of SWI, you can see the true extent. Another example, this is a patient with medulloblastoma treated with radiation. Here you can see small areas of low signal intensity in T2, which is diagnostic for radiation-induced telangiectasia. But if you look to the SWI, if you look to the SWI, you can see again the true extent of the disease. So the area of radiation-induced telangiectasia are seen much more better in SWI images. In cases of cerebral venous sinus thrombosis and venous infarction, also the SWI has a very significant importance. Look to this example. This patient has a loss of normal signal void in the superior sagittal sinus in both T1 and T2, which is indicative of sinus thrombosis. Look to the SWI. You can see a large area of blooming artifact at the site of the thrombus. And look to the secondary sign. There is an engorged cerebral veins all over the cerebral hemispheres because of increased cerebral venous pressure. In the follow-up after partial recanalization of the thrombus, now look to the caliber of the cortical veins. So SWI is a very important tool in cases of superior sagittal sinus thrombus or venous sinus thrombus in general. It's a very helpful tool in combination with MRI angiography or MR venography. So again, look to this image. So you can see a linear area of blooming artifact, which is diagnostic of cortical vein thrombosis. Sometimes it's very tricky to diagnose such patients in CT and MRI. Again, this is another example in our practice. This patient present to the A&E with headache, and only the positive finding is subtle area of hyperdensity at this region, which looks something extraaxial, which could be focal subarachnoid bleed or cortical vein thrombus maybe. And this is on the gradient. Still you can't differentiate between cortical vein thrombosis or focal subarachnoid hemorrhage, and SWI actually in these cases will be very helpful. What about the arterial stroke? In cases of acute cerebral infarction with or without hemorrhage, it can be diagnosed with SWI. And vascular occlusion causes susceptibility changes by decreasing the arterial flow and increases pooling of deoxygenated blood, thus leading to high concentration of deoxygenated hemoglobin. In the setting of acute stroke, such as conversion to deoxyhemoglobin can occur as early as 2 hours after the onset of the symptoms. In the setting of stroke, SWI assists to identify hemorrhages within infarct region, thus enabling the differentiation of a hemorrhagic from a planned ischemic stroke. Many studies have also proven that SWI is more sensitive in revealing hemorrhage within the acute infarct regions than CT. SWI also can detect acute subarachnoid hemorrhage and is very sensitive to subarachnoid and chronic subarachnoid hemorrhages, sometimes missed by CT and FLAIR. Acute intraarterial thrombus. The susceptibility vessel sign is defined as the presence of hypointensity from subacute deoxygenated hemoglobin or deoxyhemoglobin thrombus within intracranial arteries in which the diameter of the hypointense vessel exceeds the contralateral vessel diameter. Let's have an example. This is a classic stroke in diffusion weighted image at the right MCA territory. If you look to the SWI, here's the thrombus in the right MCA. Compare this with the CT angio. The same findings. So without giving the patient contrast, without exposure to radiation, you can diagnose the site of the blockage in the artery. Another example, this is a classic stroke again in right PCA territory, and this is the site of blockage at SWI. Look to the CT angio. Again, you can identify the same point of blockage without, in the SWI, you can identify the same thing without using IV contrast or exposure to radiation. Another example, this is an infarction in the right MCA territory, in the left MCA territory, sorry. And this is the site of blockage in the left MCA. And look to the engorged veins in SWI, secondary to increased venous pressure. This is hemorrhage within the stroke, and it's bright in phase image, and that's how you can confirm that this is a blood and not calcification. So with SWI, you can see the site of blockage, you can see the secondary signs which increased venous pressure, you can identify hemorrhage within the stroke. Further example, this is stroke at the left MCA territory. This is the T2 weighted image, and look to the SWI. You can easily identify large areas of hemorrhage within the stroke, and it's bright in phase image to confirm that this is a blood. So now you can see the hemorrhage within the infarction and diagnose hemorrhagic infarction even if it's not seen in regular MRI techniques. In cases of brain tumors, SWI can help in the grading of cerebral tumors because it provides an idea about hemorrhagic and calcified foci inside the tumors, and also allow assessment of the detailed internal angioarchitecture of the tumor. High-grade tumor like glioblastomas usually contain a hemorrhagic component. In the majority of cases, SWI was equivalent to T1 post-contrast images in the grading of gliomas. Look to this example. This is a space-occupying lesion at the right front region with significant surrounding edema and mass effect. In the post-contrast, it shows marginal irregular post-contrast enhancement. And look to the SWI. You can have a picture similar to the post-contrast without using the contrast material. So this is areas of hemorrhage and new angiogenesis. SWI also can use to distinguish vestibular schwannomas from cerebellopontine angle meningiomas. So microhemorrhages occur with schwannoma but not in meningioma. And look to this example. This is a space occupying lesion extraaxial at the left CP angle. And this is the post-contrast study. Look to the SWI, you can identify small foci of micropleats within. And it's bright also in phase images. And this is diagnostic of schwannoma. Before going to the conclusion, so what's the limitations of SWI? There's undesirable magnetic susceptibility sources that cause artifacts occurring at air tissue interfaces, such as the area of adjacent to the temporal bone and sinus, which limits investigation of these regions. The blooming artifact also, which is a useful sign of detecting a source of micropleats, may sometimes leading to extreme tissue signal cancellation and loss of the anatomical borders. So to conclude, SWI is a very useful imaging tool with a variety of applications in neuroradiology practice and should be included in routine protocols. These are the references, and thank you so much.